Welcome. We'd like to invite you to join us tonight for a very exciting Empower Lipoprotein a meeting. And I'm Susan Ward. I'm a Family Heart Ambassador. I'm also a nationally board certified health and wellness coach and certified lifestyle coach for the National Diabetes Prevention Program. So tonight we have a really exciting presentation. I am very thrilled that we're going to have as our featured guest, Dr. Amit Khera from the University of Texas. He's a preventive cardiologist, and I'll get to his resume later, but we'd like to get started and just give you a few tips here. Tonight we are in a webinar format, so we could have more people join us. Your video will not be shown and you will be on mute. So if you would like to put where you are coming from, where you're residing or calling in from in the chat, you can just go to the bottom of the page and you will see the dashboard, and you can put your information in the chat. And later on, as Dr. Khera gets into his presentation, if you have questions, you can put those in the chat and we will deal with that after the presentation is completed and go through your questions. So tonight, our topic is managing risk with elevated lipoprotein a, the benefits and side effects with lipid-lowering therapies. Earlier this year, we queried the support group to know what topics we should cover, and some of you were concerned about certain medications that might cause a rise in your A1C or even bring on new onset diabetes, and you wanted to know more about the risks involved here and what the solutions might be. So we'll be getting into some of that and other things that Dr. Khera will share with us. I'd like to thank our sponsors. The Family Heart Foundation gratefully acknowledges the generous support of our sponsors for the 2025 Lipoprotein a Community Activation Program and LPA Awareness Day. And Lilly is the sponsor of our LPA Community Activation Partner level, and Novartis is the sponsor at the champion level for LPA Awareness Day. I'd like to also mention that I have on this call today from the Family Heart Foundation, Misty Votaw, who is a community engagement associate helping me in the background. Misty, do you want to just say hello real quick?
Hello, I am here with Susan and Dr. Kara tonight. I'm going to help moderate the questions. If anybody needs anything, I'll be watching the chat, and I am going to help with any other things you guys might need. If you want to ask questions or anything else in the chat, I'll be looking for that. And we appreciate you guys being here tonight. We're excited about it.
Thanks, Misty, and thank you for being here to support. So I'd like to just go over a brief medical disclaimer. Today's program is for your informational and educational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, nor does your participation constitute a medical or coaching relationship with the presenters or employees or officers of the Family Heart Foundation. Future research may impact today's presentation. Information may be updated or changed in subsequent presentations. Follow up with your medical professional for specific recommendations pertaining to your or your family member's diagnosis or treatment. And reach out to a Family Heart Foundation care navigation specialist for further resources. And you can find that center, the Care Navigation Center, at familyheart.org. And at the end, we might be able to provide a screen about that. So now I'd like to introduce our featured guest, preventive cardiologist, Dr. Amit Khera. He's a professor of medicine at the University of Texas Southwestern Medical School in Dallas. He's a clinical chief of cardiology, director of preventive cardiology, co-director of familial hypercholesterolemia clinic, and holder of the Dallas Heart Wall Chair in hypertension and heart disease. His clinical and research interests include the primary and secondary prevention of coronary artery disease, focusing on risk assessment and risk factor modification in those with premature and familial disease. He has a medical degree from Baylor College, internal medicine residency at Brigham and Women's Hospital, Harvard Medical School, cardiology fellowship at the University of Texas, Southwestern Medical Center. And he has a master's in epidemiology from the Harvard School of Public Health. He's a past president of the American Society for Preventive Cardiology, and he has and Master of the American Society for Preventive Cardiology in 2023. He's also Associate Editor for Circulation and the American Journal of Preventive Cardiology, and he has contributed to more than 200 publications in the field of preventive cardiology. I'd like to welcome Dr. Khera and have you share your screen, and we can't wait to hear what you have to tell us.
Thank you, Susan, for that very kind introduction, and thank you for inviting me. I really, these are some of the most enjoyable things I do, is get to talk with people and individuals and help hopefully share some things that are helpful for them. As you know, one of the things we're going to try to do tonight is have a fair amount of time for Q&A. So if questions come up, I hope they do. That's always the most fun. I'm going to switch. If you're going to stop sharing, Susan, then I'll take over. Perfect. Let me share my screen. Give me 1 second. Okay, let me know if you can see this.
Yes, we can see
Okay,
it.
perfect. Let me also say, as I was just, we were getting started, how amazing it was to see people from all over the country and Canada, and really fantastic. I love these webinar formats, so we can really have so many people participate. But again, thank you for this kind introduction and for allowing me to do this and inviting me. The topic I was given was to talk a little bit about benefits and side effects of lipid-lowering therapy. And I know that there was some particular interest around statins and diabetes, so I want to make sure I cover that. I definitely will cover that in my slides, but if there's additional questions, then I hope they come up in the Q&A. With that, let me start with some background. And again, I apologize to this group. I know this group is pretty sophisticated, knows so much about lipoprotein A, and I'm certain I could learn a lot from this group. But I did want to level set, not knowing everyone who's on the webinar, and also appreciating this will build up to a concept I'm going to come to in just a minute. So I do want to go back to some of the basics about lipoprotein A and risk, and we'll build up to sort of where am I going with this in just a minute. So well known to this group, lipoprotein A is a unique molecule. It's essentially a LDL bound, covalently bound to this apolipoprotein A that has these Kringle repeats. It's a funny molecule because for many reasons. One is, as everyone knows on this webinar, that so much of it is genetically determined, up to 90% of it. But the way that it contributes to heart attacks and strokes is it's prothrombotic. It causes clotting issues for various reasons, has to do with maybe the way it looks, and it looks like something called plasminogen, and so it can promote blood clotting, but also for various reasons can actually cause atherosclerosis. It's more inflammatory. It gets retained in the walls. It carries this thing called oxidized phospholipids. So it has sort of both of these bad properties that lead to more predominantly heart attacks, and we'll talk about in a second, strokes as well. So bad things and specific biology that relates to that. Now, again, background for most of the people on here, but just reminding us that it's predominantly genetically determined. My colleague here at UT Southwestern, Helen Hobbs, wrote one of the seminal papers saying 90% of it's genetically determined. Maybe it's 75%, but the dominant component has to do with genetics, not what people eat, their lifestyle, et cetera. We do know that there's two different assays. I just mentioned this because I'll be talking about some numbers. And again, I know this is a pretty sophisticated group, but just to remind you, there's two different lab tests. There's a mass one in milligrams per deciliter, and then there's a particle concentration or molar one, nanomoles per liter. They are not the same. With the mass assay, if you're above 50, that's considered elevated per US cholesterol guidelines. For the nanomole one, it's 125. Again, most people on this call, I think, would be familiar with that, but occasionally I'll see people get one value with one lab and one value with another, and then think their numbers got so much better or get really anxious because they got so much worse. And in truth, they're likely the same number, just a different type of test. Final point on this is just background, again, level setting, to remind us what are people saying about measuring lipoprotein. Just talking to Susan and others before this, it's so many people are getting it measured now, which is great, because previously it was just unknown in so many people whether or not it was elevated. The US cholesterol guidelines in 2018 called it a risk enhancing factor and said, maybe it should be measured in those with a family history of heart disease or who have a history of heart disease that's not explained. A little bit more conservative. The Europeans in 2019 said everybody at least once in a lifetime. And I think that's where a lot of the other guidelines are going, is moving towards everyone getting it measured at least once. So, we're not missing individuals with high lipoprotein A. Okay. A couple of things about risk that I also want to share. Again, I think we're here, all of us, because we know that this is an important risk factor for heart disease. Let me break this down more specifically about some nuances. So this is an analysis of 70,000 individuals from the Copenhagen General Population Study. I'll start with heart attacks, myocardial infarctions in the top left. If you go to the bottom, you can see the corresponding lipoprotein A levels. Let me actually put on my pointer so you can see this. Okay, so if you go to the bottom, 0, 105, 214, 323, what I want to show you is that the risk of lipoprotein A starts to go up probably well under that 125 level. And so even though we use these cutoffs, they are a little bit, I don't say arbitrary, but doesn't mean that there's no risk building up below those levels. But certainly as the level goes up, the risk of a heart attack goes up significantly. So I'll come back to this, but obviously it's not do you have a high lipoprotein A or not. It's actually what is the level, because the higher the level, the worse, the higher the risk, which is intuitive to most people here, but I'll come back to that point in just a second. It also relates to higher stroke, ischemic stroke on the right, but not quite as much with strokes as it is heart attacks. Still, the risk is higher, but you can see that slope is a little bit flatter. Heart failure is probably because of via heart attacks. But again, I was talking to Susan about aortic stenosis beforehand on this call, but we do know that lipoprotein A is an important risk factor, causal risk factor for aortic stenosis. So take home is myocardial infarctions, aortic stenosis, stroke as well, but that risk seems the actual level matters, and that it probably starts to accrue even below these magic cut points of 125 or 50 and so forth. Okay. So I want to talk a little bit about a conundrum that has vexed me and something that I've kind of done some research projects to try to understand. One is, I think, again, this group is well familiar with, as we've learned, lipoprotein A is common, not just in the United States. I know some people are from Canada, but around the world. And if you look in, as best as we can tell in the studies that we have, about 1 in 5 people in North America, 20%, same in Latin America, similarly in Europe, Africa, really around the world, we're seeing this number. So it's not unique to the United States, but really around the world, about 1 in 5 people, or, so we're looking at about 1.5 billion people worldwide. That's an immense number of people. What an important risk factor, in terms of just the number of people that are affected by it. So obviously great work by this organization to spread the word and help people get screened. So this is quite important. So here's the conundrum I got into over the years as I've been thinking about lipoprotein A and see lots of patients with an elevated lipoprotein A. So first, you might have seen the story several years ago about this gentleman. He was if you remember this old show, The Biggest Loser, where people were in a weight loss challenge, and it was on TV. So, people knew about different folks on this show. This gentleman was the trainer. He was young, healthy. Look at him. He's the trainer. He's the model of health. And he had sudden cardiac death at his gym. Thankfully, he was revived and is doing okay, but had a heart attack. And he found out he had a high lipoprotein A. And this is obviously what I call the severe premature disease. And I take care of many patients that have this. And unfortunately, I'm certain the people on this webinar that have had pretty significant heart issues as related to lipoprotein A. So on one hand, we all want to find these people, make sure that we're treating their risk factors, and being quite aggressive about avoiding these problems in those with high lipoprotein A. The conundrum, though, is that 1 in 5 people in the world or in the United States don't have this history on the left. So 1 in 5 have an elevated lipoprotein A, but 1 in 5 don't have this history. What that tells me is that there has to be more to it. That it's lipoprotein A plus, and I'll talk a little bit about what those pluses are. And the take home, why am I going through this? Because the first question before we get into treatments and side effects is who needs to actually be on treatment? And I spend a lot of time in my clinic to figure that out, not by myself, but with the patient to help with shared decision making about is treatment needed with cholesterol medicines or not. So again, there's pretty severe and extreme cases that we want to avoid, but 1 in 5 people don't have this extreme presentation. And so we need to figure out what else is involved here. So another, just to advance that concept about the background, that the LPA level, so we talk about the level itself matters, but so does the background. And by background, I mean other risk factors. So people's age, blood pressure, cholesterol, diabetes, smoking, these things matter. And let me show you that here. This is an analysis of 415,000 individuals in the, what we call the UK Biobank. So at the bottom, it says baseline risk of ASCVD events, atherosclerotic cardiovascular disease events. So 5%, 10%, 15, 20, 25. They estimated these by putting people's blood pressure, cholesterol, et cetera, in a calculator and said these are people's risks that increased. Now, on this other axis in red is the actual lipoprotein A levels in these individuals. So 7, very low level, and then on the, sorry, this in milligrams or 16 nanomoles. If you escalate over to green, these are very high levels where people are, 350, really high levels. Let's stick on this green group for a while. So if you're in this green group, have a very high lipoprotein A and your estimated risk based on you had a lot of risk factors for heart disease, your risk may be as high as 43% to have a heart attack or stroke. But if you have the same really high lipoprotein A level, 350, everyone would agree is a very high level, but your other risk factors were low, maybe you're younger, maybe you don't, your cholesterol is perfect, your blood pressure is perfect, your risk was 8.6%, markedly lower than the 43s. Same LPA level and very different actual risks that people have. And again, because it tells you that it is the LPA, but it's also the background that matters. So not just the LPA, but other risk factors that help inform who's at highest risk of having heart attacks and strokes. Two other things I want to share with you. This is a paper we did. I used to always see people with, as I mentioned, that poor gentleman that had the significant heart attack at a young age. In my practice, I see a lot of people with strong family histories and high lipoproteinase, and there seemed to be something there. So we actually studied that here in the Dallas Heart Study. And we took all the individuals in the Dallas Heart Study, and we looked at their lipoprotein A levels and whether or not they had a premature family history of heart attacks. So let's start with this bottom group. If you had your LPA was normal, not elevated, and you did not have a family history, that's our reference group. If we move up one group here, if your LPA was high, but you did not have a family history, your risk was 1.24, 24% higher. So that's important. If you had a family history, but not a high lipoprotein A, your risk was 1.29, 29% higher, so very comparable. But here's where it got interesting. If you had both, an elevated lipoprotein A and a family history of premature heart disease, your risk was about 8-fold higher, so markedly higher. That's something I see a lot clinically. I know this is research, but so one important modifier to understand someone's risk with a lipoprotein A, in my opinion, is to understand their family history. And my point here is it may not just be additive, it could be even a multiplicative or exponential. So I'm going to pivot and talk about a different test, again, a modifier of lipoprotein A, and that's knowing about atherosclerosis in the arteries and specifically about a coronary calcium scan. Now, again, there may be many people on this webinar that have had this scan done before, some have not. Let me explain to you what it is. So what a coronary calcium scan is, a CT scan of the heart. It's a really quick one. It just takes a few minutes. I've had one myself. And so on the left here, this is what the scan looks like. And you might imagine that someone's feet are sticking out of the screen one way and their head the other way. This white up here is their breastbone. At the back, at the bottom is their spine. And so this is their heart in the middle. And this white with the wording LMA, LAD, this is a coronary artery, left anterior descending. And this is white stuff is calcium in the artery. So it's a quick and dirty test to essentially say, if you have calcium, as I said down here, you have atherosclerosis. So don't have to inject any dye or anything. And very quickly, we can say, do you have atherosclerosis, the plaque buildup in your heart arteries? One caveat, if sometimes you can have a calcium score of 0 and still have some atherosclerosis. So that happens. But the bottom line is the more calcium you have, the more atherosclerosis you have. And on the right, this is a paper we published, but many, many others have done the same. It's pretty simplistic. The higher the calcium score, the more plaques in your arteries, the more plaques in your arteries, the higher the risk of a heart attack. So not rocket science here, but just to show you, if your score is 0 down here, you have a very low risk of heart attacks and coronary artery disease in our follow-up of about 10 years. If your score is above 100, you have a significantly higher risk over the next 5 years, about a 3 to 5-fold higher risk. So bottom line is a calcium score is not a perfect test, but it's a pretty good crystal ball, one of the better ones that we have in terms of someone's risk as we try to individualize it amongst everybody, and in particular amongst those with the high lipoprotein A. Well, one of my colleagues, Dr. Parag Joshi here at UT Southwestern, I was involved in this, but this was really his paper, and it was really looking at this 2 by 2. So the question was as follows. His real question was, if you have a high lipoprotein A and your calcium score is 0, are you still at high risk? That was the question that he wanted to start with. But let me break that down for you. So lots of lines here, but let's start with the flip of that. These are from the MESA study of over 6,000 people. They looked at lipoprotein A levels and how much calcium you had on these scans in your arteries. If your lipoprotein A level was in the 5th quintile, the top 20%, and you had a calcium score above 100, you had a pretty high risk, in the next 10 years, about a 25% risk of heart attacks or strokes. Let's go all the way down at the bottom here. If you had neither in purple, if you had no calcium in your arteries and your lipoprotein A wasn't that high, your risk was pretty low. It's a good thing. But the yellow group was the most interesting. Okay, what if your LPA was high, but your calcium score was 0? Your risk was actually not that high. So even though the LPA was high, if we're not seeing anything in your arteries at a sufficient age, in this study they're between 45 and 85, then maybe, maybe the LPA, the risk accompanying that, your overall risk is not quite that high. So again, another example of a modifier. So let me put it all together. I kind of covered different topics, and the point was to build up to this. Before we get into you're on a medicine, you're getting side effects, or what are the side effects? I always do this, and when I have trainees and fellows in clinic, I stop and say, let's first discuss, do they need to be on a medicine? And so, factors to consider if you have a high lipoprotein A as it relates to cardiovascular risk. Do you need to be on a cholesterol medicine? Well, the first thing is, how high is your level? Is it an LPA of 105 or 400? Those are very different. Second, I talked about background matters. What other risk factors do we know? Do you have diabetes? Do you have high cholesterol? Do you have high blood pressure? What's your age? All these things matter. Family history, I hope I made a good case for it, but I think that's really important in that if you also have a family history, that makes me concerned always in managing patients with high lipoprotein A. And then finally, these scans, whether it's coronary, I didn't get into carotids. So many people have CT scans. I was in clinic today. Someone had an abdominal CT scan. I could see their aorta, and there was some atherosclerosis in the aorta. It was free information. They'd already had the scan for another reason. So I always like to look for that. Is there evidence of atherosclerosis on the different scans, or should we order a calcium scan of the heart to help determine, does someone need to be on a medicine or not? Okay, with that in mind, let's go through what sort of therapies we have. And this is not exhaustive, but a handful of things to raise some points about what are the treatments. And of course, we're going to talk a lot about cholesterol-lowering medicines today as we think about how to address lipoprotein A and the cardiovascular risk. So I want to note, break down when we think about any therapy or approach, what things have proof for lowering cardiovascular events and what things have proof for lowering lipoprotein A, and what do we learn from that? So we know that lifestyle, exercise, and diet, as best as we can tell, particularly Mediterranean pattern, can lower cardiovascular events, but may or may not affect lipoprotein A, as that we're learning a lot about what lifestyle changes actually make changes in lipoprotein A. We're not sure. These are not available, but there are at least 5 drugs currently in development, 3 in later phase trials, where they directly lower LPA and markedly lower the LPA levels, but we're still waiting to find out whether or not they lower heart attacks and strokes. Hopefully we'll find out next year, as I think most know on this call. Statins. That's going to be a big focus tonight. What I wanted to bring up is statins definitely lower heart attacks and strokes, unequivocally, and we'll go through the data. But statins don't necessarily lower LPA, and they can actually raise LPA. So there's a little bit of a disconnect in terms of, and to me, the most important thing is, do these things lower your risk of a heart attack and stroke? Also interesting if they lower lipoprotein A, but they may lower heart attack and stroke even if the lipoprotein A doesn't go down. And that's where statins come in and how we think about them. Even if we can't control the lipoprotein A, if we don't have a medicine to lower it today, can we lower your risk of heart attacks and strokes regardless? I'll talk a little bit about these last two medicines in just a bit, PCSK9 monoclonal antibodies and inclisiran. Okay, statins. All right, so it's really important to spend a minute to realize I was a history major in college, so I like to go over this a little bit. You know, statins have been around now almost 40 years. That is a long time. There are few medicines in all of society that have more data and have been studied longer. And as I like to tell my patients, that the good news is there's a huge track record. There's not a lot of secrets here. The bad news is we know every problem because they've been around for 40 years, so they've been well studied. So we'll go over those tonight. There are 7 different statins. Um, uh, we can go over if there's questions about how you pick between them. Atorvastatin and rosuvastatin are the strongest. And so those are generally the ones I use and probably have the least drug interactions. And they also are generic and cheap. So, that makes sense to me about using cheap drugs that have been around for a long time, well studied, and are pretty potent. So again, really, really long track record, 1987. I'll have to take it a little aside. We always talk about this in clinic. Many people come to us concerned about statins. I understand, and we'll go over those, and they're worried about, maybe some unknown things that we don't know, but yet everybody wants to take Ozempic, and it's only been FDA approved for 7 years. So there's a disconnect, in terms of track record and what's known and what's not known. There's a lot known here, and we'll go over some of those side effects. So why statin? So one is, again, long track record. The other is we have a lot of data. I'm a cardiologist in an academic medical center. It's all about the data. Each one of these boxes is a randomized trial. Each one of these has more than 3,000 people studied. There's a wealth of data with statins. And the bottom line is, and I'll go over this in the next slide, they absolutely lower heart attacks and strokes, unequivocally. It's more about who needs them and what's the dose and which ones. But they unequivocally lower heart attacks and strokes. So we have all that evidence. So if we're going to have someone take something, we want to know that it actually benefits them. This is a meta-analysis just summarizing what I just verbally said. I want to show it to you numerically. A lot of numbers on here, but this was even, this was even 15 years ago. There have been more statin trials since then. But 15 years ago, over 170,000 people have been studied. And these are different types of things. So the first one's non-fatal heart attack, coronary death, stroke, major vascular events. Anything on the left side of this line says statins are benefiting those events. So all across the board, statins lower the risk of multiple types of cardiovascular events. And if you summarize it, for every 40 milligrams per deciliter that you lower your LDL cholesterol with statins, you get a 22% relative risk reduction. So if I lower your LDL by 80 points, you'll get a 44% relative risk reduction. So part of it depends on how much we're lowering you're actually lowering your cholesterol, but all told now in over a couple 100,000 individuals, statins work, they're beneficial, cheap, generic, long track record. That's why they're our first line. Well, with that, let's talk a little bit more about some of the mechanisms and get into the side effects. So how do statins work? Sorry, this is a little bit blurry, but statins, there's an enzyme up here called HMG-CoA reductase. It is the rate-limiting enzyme. If you're in the liver cell, you have a series of steps that ends up with the production of cholesterol. So when you block this rate-limiting step, they're called HMG-CoA reductase inhibitors. You block this, you decrease cholesterol production in the liver. And so one is your liver has less cholesterol, and so it's making less to go out into the body. And then also other things happen. You get more LDL receptors that pull cholesterol out of the blood to bring it into the liver to raise the cholesterol concentration. But short story is that you block this rate-limiting enzyme and you decrease cholesterol production in the liver. I will say, for those that are paying attention, there's this funny guy over here called ubiquinone. You might know another name for that is CoQ10. So it does lower some can lower CoQ10 levels. Some people take CoQ10 for muscle aches with statins. We can talk about that in the Q&A. But there is some other things that happen outside of just cholesterol lowering. Okay, let's go through the side effects. So I'm going to talk about muscle aches, and I'll do that in detail in just a minute. Liver function, I'm not going to talk about that, but I do want to spend a second because this comes up a lot in clinic where patients will ask and really concerned about statins in their liver. When statins first came out, there was some concern about the liver, but after the first few years, it was pretty clear that statins don't cause significant liver damage. And the FDA so much in 2012, if you Google the statement, they said they took it out of the package insert and said we do not need routine monitoring of liver function tests. And we generally say, even if they go up a little, because they can, if they're less than 3 times the upper limit of normal, they're just a little bit elevated, it's inconsequential and we really don't make any changes. So when statins first came out, more of a focus, but really has been disproven as a major concern for most people. Diabetes, I'm going to talk a lot about that today. That was what I was asked to talk about, so I'm going to spend some time on that. And finally, I won't talk about cognitive issues happen too in the discussion, but it comes up a lot that, there's case reports and FDA in the same 2012 statement mentioned that there's case reports, meaning there's an occasional individual that say that I think this affects my thinking. I'm happy to talk about that, but I think the evidence is that that's not a, I understand why people are concerned about it, but not a major issue with statins. Okay, let's talk about muscle aches and spend a few minutes on that. Well, how common is that? And it kind of depends on what kind of study you're looking at. In these big trials I showed you, well-controlled, or, you get the right patient and it's not always a real world setting, but maybe 1.5 to 5% of the time we'll hear about muscle aches. In observational studies, meaning just looking in the real world, who's taking statins and who's not, maybe we're closing in on 10%. And I will say that it is dose dependent, that when muscle aches happen, the higher the dose, the more common in general. And so maybe even higher. Bottom line, it's about 10% of the time people can get muscle aches with statins. And I think, at least in my clinic, that's something that comes up a lot that raises a lot of concern. I like to remind my patients that means you have a 90% chance of not having a muscle ache. So the vast majority of people, it's not going to happen, but it can. I appreciate that it can. But for most people that are just concerned about the possibility and have never actually had that problem, there's a 90% chance that won't happen. And importantly, for the vast majority of people, when you stop the statin, the muscle aches go away. So I understand the concern, but not very common in general, and usually resolves pretty quickly as soon as you stop the medicine. Now, why? Good question. Not that we don't know this for sure, but there's probably a few different reasons. That in the muscle membrane itself, you're decreasing cholesterol. Maybe that affects some muscle function. You deplete this CoQ10 that I mentioned, ubiquinone. Maybe that has a role. You might affect mitochondrial function. Some people may be more susceptible to that, the powerhouse of the cells, people that may have underlying mitochondrial disorders. So maybe all of these things, but again, despite this mechanistic findings, those are in people who have this issue, which is the minority of patients, of only about 10% or less. So I want to just raise some interesting studies, and this gets to attribution. One of the hardest things in clinic, and frankly, probably for those that have taken statins, is to know when you're taking the statin and you feel something, is it actually the statin? I use the word attribution. It's a very hard thing when patients call me and say, I'm having muscle aches, I wonder if it's my statin. It's very hard to tell. And let me give you an example of an interesting and neat study that a group did, and kind of a way forward. We call them N of 1 trials. And there's a lot to learn from this N of 1 trial. What they did in this study, they took 60 patients that had statin side effects. So they had muscle aches or otherwise, and the doctors knew it. And it was a double-blind trial, so this is really important. And they took these patients and they said, hey, we want to figure out if these muscle aches are due to your statin. Are you game to try to figure this out with us? And then they gave them a 1-year supply of medications. Let me talk to you what that meant. They got 4 bottles that were empty. The patient knew it was empty. The doctor knew it was empty. They're not taking anything for those 4 months, for that each month. 4 of the bottles, 1 month each, were placebo. Neither the doctor, double blind, or the patient knew what it was. So neither one of them knew what it was. And then 4 of the bottles were atorvastatin, were the statin. Now, they were asked then on a computerized program on a scale of 0 to 100, talk about your symptoms that day, symptom intensity score. So this is what was really neat. After they finished the study and they did all the logging, they kind of unblinded and said, okay, let's figure out what you were on each month. When they were on the statin and they knew they were on the statin, their symptom intensity score was like here, like 15, 16. When they were on an empty bottle, their symptom score was really low. But here's what's interesting. When they're on a placebo, there is no statin in there. Their symptoms were the same as the statin. So this is called nocebo, meaning the knowledge of taking something, you feel something because the knowledge that sort of the mind's a funny thing and how it plays tricks on us. So it's not that these people were making it up or anything like that. It's just that the knowledge of being on the medicine was enough to maybe manifest symptoms. So this is what makes it really hard, because it's always hard to tell, is it the statin or the concern about being on a statin, which is the placebo or nocebo here? Because when they're on none of it, and they knew they were on none of it, the risk was a lot lower. One really interesting thing is this was a positive end to this study. They went back to these 60 people. They showed them these data and said, hey, I'm not sure it's a statin based on this. When you weren't on anything, when you were on placebo, it was the same. And 30 out of the 60 were able to take a statin once they were able to sort of work past that. So kind of interesting when it comes to muscle aches. All right, let's talk about diabetes. It's really important first to understand a fundamental concept around blood sugar and this concept of statins causing diabetes. Let's remind ourselves what's normal. You can use a fasting blood glucose, or you can use an A1C, which is a measure over the last 6 to 8 weeks. So less than 100 or an A1C less than 5.6 is normal. Pre-diabetes is 100 to 125 or an A1C of 5.7 to 6.4. And frank diabetes is when you're at 126 or an A1C of 6.5. So I ask this question all the time. If you're 124, technically you're not diabetic. And if you're 126, you're diabetic. That is the fact. That is the diagnosis. But I think everyone watching this knows that those aren't really that different, right? And so if your blood sugar goes up a few points, technically speaking, if you're on the fence, you caused diabetes. But that's not the same that people fear that everything's fine and normal and there's no problem. And then all of a sudden we're causing a severe disease that you go from way over here on the left to way over here on the right. That's generally not what's happening with the statin. And I'll walk you through what that means with some evidence in just a second. Okay, before I do that, this is probably one of my favorite studies in all of prevention. And it's a really positive message about what do you do if you're pre-diabetic and your blood sugar is borderline, or if, the statins are raising your blood sugar a few points. First is lifestyle really, really, really matters. This is the diabetes prevention program. I think Susan said she works as part of this. These are patients that were pre-diabetic. So, kind of the cases I'm giving there. And a third of them did placebo. A third of them took a drug called metformin to lower blood sugar. And a third of them really worked hard to lose weight and exercise. They targeted 7% weight loss greater than 150 minutes a week of exercise. And they looked about 3 years later, metformin did lower the development of diabetes by a third, by 30%. But weight loss and exercise lowered the development of diabetes by 60%. And I see this all the time, that it's hard to do, but for those that can really lose weight and exercise, you can really regress that pre-diabetes, improve blood sugar levels. So really an important opportunity. So where does that bring us about statins and diabetes? I'm going to walk through the Jupiter trial first, because there's a lot of neat learnings here. It's a huge study, 17,000 individuals looking at rosuvastatin versus placebo, determining about statins and cardiovascular risk. There was something to do with inflammation in this trial, but a little bit of a side issue. And what they did was they followed up and then looked at those who had some no risk factors for diabetes, 6,000 of them. And then they looked at the 11,000 that had at least one risk factor to develop diabetes. What were those risk factors? Metabolic syndrome, prediabetes, or they were already obese. So now let's walk through this. If you did not have any diabetes risk factors in the study, you did not have any new cases of diabetes. You did not, quote, quote, cause diabetes. If you had a risk factor, you're already on your way to diabetes. If you're already pre-diabetic or metabolic syndrome, you're already, as I mentioned, you're already on this spectrum here. You're already kind of over here in the yellow, and it pushed you over the top. And there was about a 20% increased risk in developing diabetes. But I want to be clear, to me, that's increased your blood sugar a few points and you crossed over that line. But here's the important point. If you had risk factors for diabetes, you reduce your risk by about 50% of cardiovascular events. If you did have risk factors, you reduced it by 40%. Well, what about those people who develop diabetes? So statins, quote, quote, caused this diabetes. Well, what happened to them? They had a 37% reduction in cardiovascular events. So even though cosmetically their blood sugar was a little higher, what we really care about is lowering heart attacks and strokes. And that was still lower in this study. Let me take that one step forward. This is a study of patients with diabetes. So a little bit different than statins cause diabetes, but I want to even say, even if the blood sugar goes up a little bit, this is a seminal study in diabetes called the CARD study. They took 2,800 individuals that had diabetes. Half of them got placebo and half got a statin. They didn't even care what the blood sugar was. They didn't care what the cholesterol was, just statins to lower risk. And what happened in this study is that they stopped it at 3 years. They said it was unethical to keep going because there was almost a 40% reduction in cardiovascular events in the statin group with diabetes. And so now if you look at our guidelines, if you have diabetes and you're over the age of 40, we put you on a statin to lower heart attacks and strokes. So my point to all of that was, even if your blood sugar goes up a bit, we still know we're lowering heart attacks and strokes, which is ultimately what we care about most. Finally, I'll just put it together maybe to summarize a few things from the totality of studies. This is a meta-analysis, so looking at not just the one study I showed you, Jupiter, but a whole host of studies. And anything on this side of the line says increased diabetes risk with the statin that they used in that study. These are placebo-controlled trials. And if you come down here to the summary, it's 1.09, meaning it's about a 9% increased risk of diabetes. Let's just say 10% to round it up. So let me summarize about statins and diabetes. There is a 10% increased risk, so that is true. That's important. But that translates into 255 patients have to be treated for 4 years to cause one extra case of diabetes. So the risk is pretty small. It is dose dependent. So the lower doses don't raise the blood sugar as much as the high doses. So that's important just to know about that. But really, it only is important if you have risk factors for diabetes, already have pre-diabetes. It just pushes you a little further. I didn't put this on here, but one study modeled this. It means you develop diabetes 5 weeks earlier in your lifetime, meaning you're already going to go there. You're just going there a little bit faster. So I understand why that's important, but it's just a different way to give perspective and how to frame this. And the most important thing is you still lowered cardiovascular events, even amongst those who do and do not develop diabetes. And that's ultimately what this call is about tonight. Okay. I'm going to finish in just talking about a couple of other medicines. I know you, again, the group is familiar, but I'll talk about it with maybe some framing around side effects. There's other non-statins. There's ezetimibe, a pill, a newer pill called bempedoic acid. I'm not going to talk about these two, but I'm happy to in the Q&A. I'm going to talk about PCSK9 inhibitors, the monoclonal antibodies, evolocumab and alirocumab, and this other drug, a silencing RNA, inclisiran. Okay. How do PCSK9 inhibitors work? I'll just spend a minute on the biology so that I can then use that to talk about the other two. So in your cell, this is a liver cell, there's these LDL receptors that grab this yellow thing, cholesterol, and pull it into the liver. And by doing this, you're decreasing cholesterol in the blood. And also when your liver has a lot of cholesterol in it, it doesn't make any more cholesterol, so it decreases the synthesis. Now these antennas, these receptors grab the cholesterol, they come into the cell, and then they go back up to the cell surface, okay? So they come back up to the cell surface, they get recycled, if you will. When you have PCSK9, this purple guy, it binds to the receptors and then causes them to get degraded or broken down. So the more PCSK9 you have, the less of these LDL receptors and higher the LDL. So if you block PCSK9, you have more of these green receptors and lower LDL. Okay, hope that was clear. So PCSK9 monoclonal antibodies. This is evolocumab and alirocumab. I'm going to talk about evolocumab again. Many are probably familiar. Many may be on these medicines, but these are subcutaneous injections. Generally, every 2 weeks, you give it to yourself. Very easy to do. This is how these work. Again, they're antibodies, and that's why they're given as an injection, and they bind PCSK9, so lower those levels. And what's important is they markedly lower cholesterol, LDL cholesterol, about 50 to 60%. In this study, this is the Fourier trial, it took about 26,000 people. The LDL started at 90 and then finished at 30 for median level. So that's a marked reduction in LDL. And importantly, I think many are familiar, it does lower, this is one of the few medicines that actually lowers lipoprotein A by 20 to 30%. We're not sure what that means, but it can lower lipoprotein A. Also, just a side note, they do lower heart attacks and strokes, cardiovascular events by about 15%. Stopped early. The feeling is it probably would have been more than that if the study kept going. So they actually do work to lower heart attacks and strokes. So inclisiran, this is also a PCSK9 inhibitor, but it's a small interfering RNA. So it works sort of on the machinery in the liver cells that make the protein, the PCSK9. So it's not binding to the PCSK9 once you have it. What it does, it goes to the liver. You have this inclisiran that works on the mRNA, the blueprint for the protein, the PCSK9 protein, and it makes it so that you degrade this mRNA and you do not make this PCSK9 protein. What's different about inclisiran is you have to come to the office to get it. It's once you get past the first 2 doses, it's every 6 months. The important part is the studies showing that it lowers heart attacks and strokes have not been finished yet, have not been completed. We suspect it lowers heart attacks and strokes, but we do not know that, so we're waiting for that. Just to summarize these two, and then I'll get to side effects. Again, this is an antibody. This is a silencing RNA. Why does that matter? This is every 2 weeks. This is every 6 months. This one you do yourself at your home. This one you have to come to the infusion center, the clinic. And the only reason, it's not because it's any more dangerous. It's because the drug company elected to bill it through your Part B or your medical benefit, not through your pharmacy. That was a decision they made. Both of these are really expensive. That's why we don't use them more commonly. Inclisiran, these ones are a little bit stronger, 50 to 60% versus 40 to 50% LDL lowering. They both lower LPA a little bit. We're not sure what that means, but they both do. And we're still waiting on the trial for inclisiran. So let's go back to side effects about these. These do not cause muscle aches as best as we can tell. In the PCSK9, they even had a study called Gauss in patients that had muscle aches, got PCSK9 or placebo, didn't see any muscle aches, so they don't cause muscle aches. They don't raise liver function tests. The part about diabetes is unclear. Some studies say maybe, some studies say not. So I guess what I'd say is not certain, but could, but not as clear a signal as we see with statins. No cognitive issues have been studied in a long follow-up study. The main side effect is where you inject, it gets a little sore. And inclisiran can cause rarely some allergic reactions, pretty rare. But here's the main side effect is they are really expensive. So we have to make sure that you can get them approved and that the appropriate patients are being prescribed these. Last two slides. So what should your LDL be? If we're going to get on cholesterol medicines to lower the LDL, to lower the risk, what are we targeting? What's our LDL goal? In my opinion, if your LPA is high, we talked about family history, calcium scan, et cetera. If you put that all together and feel like your risk is sufficiently high that you need to be on a cholesterol medicine, at least under 100. If you have other parameters, a high calcium score, very high LPA, other risk factors, maybe at least less than 70. I do want to acknowledge that in those that have had a heart attack and stroke already, our guidelines say at least less than 70, and our European and ACC say less than 55, and the Europeans say maybe even less than 40 in people who are very, very high risk. So bottom line is this number keeps dropping as to what we should target, and that's a little bit individualized based on someone's risk. So in summary, lipoprotein A does increase the risk of heart attacks and strokes, well known to this group, but the risk is variable and other factors matter to determine the need for cholesterol medicines. It's not one size fits all. Statins are the first line drug and they have a very long track record, 1987. They do cause muscle aches, but they're kind of hard to diagnose. I showed you that N of 1 trial to know if it's really the statin or not. They can raise blood glucose. They can, mainly in those that already have risk factors, particularly prediabetes. But we also know that even if they raise your blood sugar, they lower heart attack and stroke risk, even in those who have diabetes or develop diabetes. And then finally, these last two can be very helpful for those that have side effects with statins. And so that's what we end up adding, but often in place of for people that have statin intolerance, including the other two medicines that I mentioned.